Welcome everyone to today's webinar, Value-Based Maternity Care 2.0, Building on Best Practices. I'm Chris Sosa on behalf of Becker's Healthcare. Thank you so much for joining us. Before we begin, please allow me to walk through a few quick housekeeping instructions. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you're having audio or visual complications, try refreshing your browser. You can also submit any technical questions into the Q&A box. As always, we are here to help. With that, I'm thrilled to turn the floor over to Leah Spark, CEO and founder of Wildflower Health, to kick off today's presentation.
Great. Thanks, Chris, and thanks, Beckers. And thank you to everyone for your interest in this topic and for joining us. And we have an action-packed panel today that'll hopefully be really illuminating for those of you joining. I want to introduce and welcome our panelists, starting with Dr. Fatima Naqvi, who is an OB/GYN and the ambulatory director for OB at Atlantic Medical Group. And she's there in the studio with her colleague, Kevin Joyce, who is the Vice President of Insurance Networks and Business Advisory Services for Atlantic Health System. And we're also joined from my colleague, dialing in from Santa Fe, Sarah Tepema, who is the Chief Actuary and Head of Analytics at Wildflower Health. We are not going to make this a slide presentation, but just to tee up the topic, I'm going to share literally 3 slides just to create some context and sort of tee up the discussion before we dive in. So I will share my screen. And just to walk you all through, everyone, can we see that, panelists?
Yes.
Yes. Yep.
Great. So today we're going to be talking about a really innovative maternal health program in the great state of New Jersey. And having now spent a lot of time in New Jersey, I'm very happy to say how much fun I've had there. But what's unique about New Jersey is from a population perspective in maternal health, New Jersey has really been struggling. Ranked 29th worst state for maternal mortality, more acute problems for health equity. The national rate for Black maternal deaths is 3 times that of white women. In New Jersey, it's actually 7 times, high preterm birth rates, and so on and so forth. And because of this, the First Lady of New Jersey, Tammy Murphy, actually has major initiatives that have been put in place for the past few years to really try to address this crisis, put funding against it. It's also a state with really thought-leading clinical groups, great systems like Atlantic. The leader of U.S. Women's Health Alliance is in the state, who is a independent practice consortium really driving value-based care for OB. Some of the payers in New Jersey have been really innovative, but this is not an easy problem to solve. And I think in part because of that history and context in New Jersey, you have a group of individuals in the state who've tried a lot of things and are now forging ahead with sort of the next generation of care transformation and value-based design in the state of New Jersey. And as we go through today's discussion, we're going to talk about, we've been very much in the early innings of value-based care, especially for commercial and Medicaid, especially for specialty models like OB. And we're going to talk about some of the past limitations of things that have been good to starting points, but are not enough. And those include global payments, just focusing on pay for performance, only focusing on 1 or 2 procedures as a source of savings as opposed to a really global strategy. And then talk about where we can go. What's the promise of tomorrow? Really looking at episodes like OB and newborn as total cost of care, looking at it not with just L&D or just with outpatient practices, but looking at a coordinated network of providers across both, looking at ways to use value-based care, not just to manage cost, but actually create investments that will improve not just savings, but outcomes, quality, improvements in equity, so that we really use value-based care to transform the system as opposed to just a payment mechanism. And so with all that in mind, the initiative that we're really going to highlight today is a program that launched in January, led by a group of self-funded employers that come together under the banner of the Healthcare Transformation Consortium. This is made up of multiple health systems who have pulled their employees together to do things innovative like this as a self-funded purchaser. Atlantic Health System is one of those anchor members. And as part of that, this group has really spurned the coming together of a multi-provider network that includes health system OB practices like Atlantic Medical Group, independent OB practices like Lifeline Medical Associates and Axia. And Wildflower's role is we really help enable in the background the methodology for total cost of care with Sarah's team doing actuarial services, and care transformation tools delivered at the point of care, which include remote monitoring, digital monitoring and engagement, as well as care coordination and health advocacy. So that's the context on what we're going to talk about. And in terms of a pacing for the conversation, we're going to spend a few minutes with the panelists talking about looking backward. Where have we been? What has our experience taught us in the early days of value-based care? Where are we now and how are we transitioning? What are our early insights? And for those of you on the call, what are really best practices if you want to begin to really use value-based care as a tool to transform the maternal quality and outcomes that we talked about on the first slide, which is really why we do value-based care. It's not really about the economics so much as it about transforming care. So with all that as an opening, I'd like to start with Dr. Naqvi. And from your perspective as a clinician, some of the early-based value-based care models have been really focused on, maybe steerage or just C-sections. What did we learn about some of those programs and how did they perhaps fall short from your perspective as a clinician?
So first of all, thank you for having me on this discussion panel. This journey for me has been one where I've learned a lot and I'm hoping to implement more changes coming through. So value-based healthcare to me means essentially where the patient's core values, their concerns, and their outcomes are centered, right? As we all know that basically value-based healthcare is quality over quantity, right? But where are we in this country right now is essentially where money that's being spent, right? So we all kind of know this 20% of US GDP is towards healthcare, right? 40% of it it's being funded through federal or state, right? When you look at this, the money that's being spent, is it being directed towards meaningful patient outcomes or not? That's really what value-based healthcare means to me. So, there in maternal health care, there's so many variations, which can be a downside, right? Like a maternity care delivery is different between health systems, different hospitals, different regions, counties, state lines, and then where US stands globally as well. But I think where we can set ourselves apart is and like you said, Jersey is a great state to be in, right? With NJ Nurture leading the way to change, to make things really meaningful for the patients, So if you were to look at these outcomes and look at patients' values, could we use technology? Could we use the data collected, analyze it, figure out which is the best practice, right? Use evidence-based practices and see which should be implemented to drive the patient to their, better health outcomes. Obstetrics is, in the past, we focused on C-section rates, postpartum hemorrhage rates. We've looked at breastfeeding rates, but to me, it's not to abandon those have to stay there because they are meaningful, but maybe in the inpatient side. Care is now being driven more on the ambulatory side. So now we have to look at what was that birthing experience like for that birthing individual, right? We have to look at those. We have to look at breastfeeding. Did the patient continue to breastfeed or not? Did the baby have a neonatal follow-up or not? So we have to look at did the diabetes diagnosis did we fulfill that commitment and get that patient where the patient needs to be with the primary care? So that continuity of care established. I think we have to look at those metrics a little bit more when we talk about maternal value-based care rather than just C-sections, just process measures, We really have to kind of bring that in alignment. Again, to me, it's more about patient being the number one, it's the patient's in the center and how that patient intersects with the healthcare system. So, yeah.
That's terrific. And I think, what you're describing is this sort of complexity of a patient journey, and a lot of factors go into play to ultimately hitting, quote, savings and outcomes. And I think, Kevin, shifting to you who've worked in this, really been a leader in the move to value for many years from my perspective, and understand a lot of the nuance, especially working with payers. Can you reflect a little bit to set the stage on maybe what have been the limitations of the past that have maybe kept us from achieving the realization that Dr. Nakvi described of really supporting this whole health for patients as it relates to the value-based designs?
Well, I think maternity, really those were focused around the physician relationships, that the plans were going directly to the physician. And quite frankly, hospitals weren't part of those discussions. And I think if you take a look at maternity in general, at Atlantic, we've made significant investments in our ACOs. We have 2 ACOs, have done very well in the total cost of care piece of it. But when you take a look at our maternity patients, only 35% of those patients are actually attributed to physicians within our ACO. So that means that 65% of those patients, we probably don't know as well as we do our ACO patients. So, you know, is there a way, is that a new value, excuse me, market opportunity for Atlantic? And we think that is. And so, you know, a lot of these patients, we don't know them until, quite frankly, their water breaks in our emergency room. Is there a way that working with Dr. Nakvi and other physicians affiliated with Atlantic Health System, we can get to know those patients way before the first time they enter that emergency room? And I think if you take a look at the overall spend on the commercial side with deliveries, it is expensive elective procedures that a payer has to pay for. And, you know, at beginning to have these conversations with our physicians around the OB piece of it, we've never had those before. And so where we started is with our own employee health plan. We working with Wildflower, we created a value-based program. We pulled in the other members of the Healthcare Transformation Consortium because, you know what, we have about 400 deliveries or our own employees out of 9,000. So by aligning ourselves with the other members of the Healthcare Transformation Consortium, we pull that number up to about 1,000. And that is enough deliveries to begin to have real conversations with our OBs and begin to build out a value-based model, not necessarily what a carrier is putting out there for us, but sitting down as the cost of care, it's hospital and physician, and we only go directly to the physicians and exclude the hospitals out of this conversation.
That's great, Kevin. And I think, Sarah, are they breaking up for you a little bit?
A little bit, yeah.
It's black.
Yeah, and your video froze. If you guys want to turn video on and off, you might come back. So, but we did catch most of that. So, yeah, Kevin, I think that is super helpful, and I think clearly one of the limitations of kind of historic.
Sorry, guys.
Yep.
Okay. Hey, man, typical. It's webinar. The web is not always our friend. While you guys are kind of readjusting, just sort of.
And not technical questions.
That's right. We can't do any tech support.
Yes.
Okay, we see you and hear you again. That's good.
Yeah.
Yes.
Oh, that?
Yes, you're back.
Okay.
Okay, good. So thank you, Kevin. I was just going to recap. I think, you're hitting something that's a really important point that has been missing, to my knowledge, in most of the maternity approaches to value-based care, which is integrating a continuum across outpatient and inpatient. And for those of you who don't geek out about maternity episodes all the time like we do, while that OB is typically the quarterback for care, and knows what's going on with the patient, most of the costs are in the inpatient, right? The L&D, the NICU, complications. And so being able to have those coordinations and feedback loops and knit them together is something that is being missed and a real opportunity. And so with that in mind, Sarah, I'm going to shift to you. And we all love actuaries, but I think you would be the first to acknowledge that there's limitations to actuarial models. And so how do you think about, from especially working in this space for so long, is it fair to say that some of the problems we've perhaps had in value-based 1.0 is maybe making these models a little bit too of a math equation and actuarial driven, and they're maybe more complicated than that? Not to put words in your mouth, but how would you reflect on that?
Well, yeah, I totally agree. And just from my experience working with value-based care, I think honestly, what it comes down to is not so much the math as you need to align your goals. What are your goals? And I think from what Dr. Nakvi was saying, I love that patient-centeredness. That's really the most important thing, is the patient. And so in our models, we can have the greatest algorithm and the greatest formula, but really what we need to look at is, what are the goals of the program? What are we trying to do? We're trying to improve outcomes. And for us, that just means a few things. It means, we want to track that mom from the minute she's diagnosed all the way through past her delivery, because we want that mom we want this to be a patient-centered model. We want her to have, to understand her care and to understand what's going on. And then that kind of leads to the second goal, which is a healthy baby, right? And so, what are those infant outcomes? And can we make sure that those are integrated into our model? So in our case, we're starting to bring in the infant whenever we can into the episode, meaning including the costs and including those outcomes of the baby beyond postpartum, beyond the delivery, but up to 3 months postpartum. And then, the third thing I think is that we want this episode to financially be meaningful for the OB and for the hospital and the other partners that are involved. So, in this case, it means that we're starting with this, what we call a total cost of care model. We've mentioned it a couple of times, but it's taking the episode and all of the costs that happen in that time period, and then excluding a few things that are just way out of the control of the providers and Wildflower. But for the most part, everything's included. And that is a different model than what you've typically seen, which is like a very complex algorithm, clinical, black box, really hard to understand. Instead, we're making it, even though it's bigger, it's simpler. So we're paring it down quite a bit. And then it makes it easy to make it transparent too, and where we can share it with our partners, with either the payer or the provider or whomever. We're trying to address some of those issues that we saw with the 1.0 models.
That's great, Sarah. And I think, just sort of pulling on that thread and summarizing sort of the first part of the discussion, we are hearing from Dr. Nakvi, like, look, this is about the patient. It's a complicated clinical journey. It's nuanced. I mean, ultimately, value-based care, if it's successful, sort of helps clinical providers, sort of be force multiplied and do all the things you need to do and have the freedom to do that, and maybe with more resources, so that those savings and quality and outcomes improvements can occur. We're hearing that it needs to be a more coordinated network for outpatient and inpatient. And Sarah, I think, you're well articulating the need for, while it's not all about the money, it is about the money, and that it needs to be a big enough pie that we can have a total cost of care and have enough there that we can we can make investments in real care transformation as part of it. And to that end, just to pull on that thread, Sarah, as we think about what is the next generation value-based models look like, I know you really advocate for making sure you use actuarial analysis, not just to do savings analysis, but have insights that can inform, what can help Dr. Nakvi's practice. And so can you speak a little bit about that and sort of the next generation models and how you help provide those insights even, before episodes are started?
Yeah, I mean, so you kind of hit it. What we heard a lot from talking to providers like Dr. Nakvi and even Kevin is, these models were fine, but they weren't getting any insights along the way. It was triggered at the delivery, and then it looked back. And for a maternity model, which is actually true of many episode-based models, there's a trigger and a look back versus like, let's find the patient from the beginning and make sure that we're tracking along the way and addressing any needs, whether it's clinical needs or social needs or whatever. And then making sure we're reporting back to that provider along the way, because I think the other thing we heard is that they just really had no idea what was going on. They might get a check at the end of 2 years, but they don't know why and they don't know how. And they certainly didn't know along the way where they were on track to, receiving savings or not. So what we've integrated an analytics model into our clinical model, our clinical support model, where we are going to be, we don't have enough deliveries yet, but we will very soon be delivering reports to Dr. Nakvi and to Kevin as the payer client, to let them know what's happening and what we're seeing in terms of like conditions of pregnancy and the prevalence of those, what we're seeing in terms of outcomes. And then, yes, also what we're seeing in terms of financial savings and where we see them on track to receive savings. So we've built an analytics platform around that. And right now we're looking at things like the digital engagement and the engagement with our health management team. But over time, we'll be also adding in the financial and the cost parts of that.
So having leading indicators, not just the lagging, savings is the lagging indicator, right?
Savings is the lagging indicator. We're looking at the leading, and then we will eventually look at the lagging. Yep.
Yeah. And so I think, Kevin, again, shifting to you, you've spoken about in the past, and you've obviously had a lot of experience with your ACO and other bundles you all have worked on. So not just maternity, but you've spoken about how in the past the providers are expected in these networks to make all these changes and investments and change in care to hit savings, and then you just have to kind of come up with how you would do it. And so can you talk a little bit about when we put this together with HTC, how we sort of took a different approach to that, and your thoughts on that?
Yeah, so the HTC, so it's Valley Health System, Holy Name Medical Center, Atlantic Health System, Hunter Medical Center, Central State, and St. Peter's. So we collectively have about 60,000 lives. We've all been on the same TPA for the last 6 years. So we had very good data on our own employee health plan. And so when we're looking at different initiatives, certainly from the Atlantic perspective, I think, we do a lot of ACO work. We do a lot of analytics. Our analytic team is very powerful. It's really finding those next tools, those next disruptors that could help us bend the premium curve in certain spaces. And so, when I take a look at, a disruptor like Wildflower, at the first thing I take a look at it and say, is this something that we could roll out with our employee health plan that could help improve the quality for our own employees, our most important asset? Is there a way that we can use that tool to partner with our physicians to reduce that total cost of care? And if we're successful across that, how do we roll it out to partner with our payer partners, our insurance carriers, and other employers in the marketplace? Because, quite frankly, I think if I'm an employer and I'm an insurance company, I think when you take a look at what we did with the HTC, bringing in the two largest OB groups or employee docs onto the Wildflower platform, that is population health. And I think that's reaching out across health systems, across provider groups. I think that's ultimately how we're going to get to a place of change and positive change. And I think if I am a local employer and I have a health system as large as Atlantic Health System rolling out these new digital tools, thinking that we're going to save money and improve quality, I think that would be on my short list of things to consider. And if that also, I think I think there's a lot of silos in healthcare. If we can find those tools and those strategies to supplement what the ACOs are already doing to partner with physicians, then I think that's just another value add that we can work on. And I think OB, especially when I go back to the fact that 65% of those deliveries are completely independent of our ACO, how do we tap into that?
Yeah, completely, Kevin. And I think, one of the things that you all did at the HTC in this model, which I think is a good lesson that I just want to hit on, because I'm going to come back to Dr. Nakvi next, is, as part of putting the model in place, we've created mechanisms where you basically pre-invest some of the expected savings at the point of care. And we're able to partner with Dr. Nakvi on, what do you need? I need RPM. I need coordination of social determinants. I need better referrals to behavioral health, better screening and engagement. And so I think, maybe because you're an employer and you value certainly the savings, but also the return to work, the whole health, you all, I think the way this model's been put in place makes the investments that will have outsized, we believe will have outsized returns in the end as part of it. And I know it's kind of helped you partner with your clinicians, and maybe you could just speak really quickly to like how this may have been different than working on a traditional payer contract to be able to partner with folks like Dr. Nakvi to put it in place.
So
You're
I didn't know Dr. Nakvi
so
was part of this project. No, it's been, I think the fact is, you know, we needed clinical champions to get this through. I think the last thing a physician wants to hear is a managed care finance guy coming into the room and say, I got this great tool for you, you know? So, you know, Dr. Nakvi has really kicked the tires. She was leading the initiative for Atlantic on the remote monitoring and those pieces. So this was just a value add. But, you know, from my perspective, without the physician champion, this just absolutely goes nowhere, and it's dead on arrival. And so I think there's been a lot of cross education. I've learned a lot from her. I think she's probably got more experience from a payer perspective than she ever wants to ever again hear, probably. So.
No, but it's so true. I've learned so much along the way, you know, and what I've always kept true to myself is, honestly, it's just my motto. It's the patient comes first. And I've said it over and over again, you know, and to me, when a patient is in front of me and I know what the statistics are, and I'm trying not to scare that birthing individual, right? Because you don't want to hit them with all the negativity. What you want to do is make sure that they have a good birthing experience, right? At the end of the day, and for them to be engaged within the healthcare community, right? So we can talk about finances, we can talk about all of this, but it really doesn't appeal to me, to my core of who I am, right? So when we talk about how do we find like-minded individuals, right? So that's what you appeal to. You have to find other champions. It's not just me. I mean, behind me is a team. And without them, I wouldn't be here where I am. So, and also cross collaboration, right? So it helps. Like, this was my point of weakness, right? Finance. That was not taught in med school, right? So, so that's something that I learned on this journey, and I'm still learning. I'm like, gosh, yeah, I didn't think about it that way. You know, how does this impact, and what do we need to do? And out of my own interest, and yes, I'm a geek in a way, but like going into, you know, learning about the state initiatives, even though I'm not on any committee or anything, but it's just valuable. It's just what I need to do to become educated. So yeah, so it goes both ways.
Well, that's a perfect tee up, because so you are now living, you know, granted, in this, I know it's only in the self-funded population, but you're living the impact of basically having a financing mechanism to bring more into your practice, the remote monitoring, the health advocacy, the digital front ends, and would just love to hear, you know, your perspective on, you know, perhaps how that has impacted you all day to day in your practice. How does it help you, you know, and especially looking ahead on thinking about the importance of health equity and the opportunities there. You know, can you see the opportunities for having you know, value-based care as a financing mechanism to help you do what you need to do? You know, what are you seeing, and what do you see as future opportunities?
So I think I look to where we are and using digital health, right? So digital health is just encompassing multiple things, right? So it's telehealth, it's the apps that are available, it's remote patient monitoring, and it's also social media, right? We all know how social media can also be leveraged to promote education and reach our patient audiences, right? So to me, it's using that, it's engaging the patient. So in our own practice, you know, we utilize telehealth and obstetrics, right? With COVID, it speeded up everything, right? We were already headed this way, I think. It just speeded up where the patients we were doing, I think, half and half during peak COVID, where, you know, hybrid models were being executed and patients were having maternity care. So we still are actually continuing that. It depends on the patient's needs. Again, obstetric care that's tailored to the patient, you know, which is like, what? I don't need to come in for so many prenatal visits. No, you don't need to come in for so many prenatal visits in a month, you know, in the whole 10 months. So there's that. And there's also how we utilize our office resources. So one of the other things is that we do is we offer our nurses in our office. They actually do all the education through virtual platform. So they don't have to come in for that. We split the visit so that its physical exam is with the physician, but actually the education. So this way the patient hears it twice, one from the physician when they physically see them and one by the nurse as well. So, you know, it allows for continuity. It allows for, even education from different people so that you get there. Even in our health system, gestational diabetes, the management of it is all virtual. Patient gets diagnosed, gets engaged with the dietitian, nutritionist, gets our high-risk nurse who's watching the blood sugar logs. So really the patient's going in for their obstetric visit and is going for their ultrasounds. The rest of it is all virtual. So with this piece where Wildflower can really help also is they have the whole advocacy, right? In behind the scene that happens. So right now, my office nurse may be spending quite a lot of time just like checking on the blood pressure logs, checking up on blood sugars. Did you make this appointment? Do you need referrals or so on and so forth? So that burden is now reallocated to, Wildflower. Like, I need you to do this for me because I need my nurse to actually do the other part of my job is GYN care in my office. So I know this topic is about maternity, but we're OBGYNs and our office resources are limited. Our patient populations are 50-50. Some practices are more OB, some are GYN, but at the end of the day, you're using whatever's available to you to help. Now, of course, this all means that we have the digital infrastructure, right? That we have the tech support that we have. And my colleagues, even though we're sitting in New Jersey, my colleagues that are providing care in or near maternity deserts, right? It becomes even more, and it's even more imperative for the BIPOC community, that we have to be able to kind of leverage technology to reach and provide equitable care, So I think you talked about the, social determinants of health and how we do that, and does screening help? I think it does. We started, actually, that was one of our goals this year, was to, on all prenatal patients, we do SDOH screening. And it's not just screening, it's actually, so the patient says she doesn't have enough food. What does that mean? Okay, well, here's your, WIC application. You don't have enough formula? Okay, here it is. But that's not what it means. What it means is using that loop, right? Making sure the patient has the resources. Did you call them? Did you make that appointment? Did you do everything? So at the end of the day, it's intervening. So it's not just screening, it's intervening on the patient's behalf so they have what they need. So I look at, technology, digital health as a way to bring that to the forefront and then reach the patient as well, So.
Yeah, it's such a good point. And one of the things we talk about a lot at Wildflower, and I know we've probably talked about with you, is that, you are sort of the center of a pregnant patient's universe, this clinical quarterback, you and your team. But for a patient to be successful on all of the, whether it's care plans or screenings or just staying healthy things you need that patient to do, there's this whole life of factors out here that impact that, right? And you can't be with her all the time. And I think the promise of technology, the promise of things like virtual care coordination or non-clinical screening and social determinant support is that those factors that ultimately impact your clinical success are able to be mitigated efficiently and effectively. And that is, I think, core to value-based care in maternity because of all the complexities you talked about clinically. So I think that, all great points. To that end, kind of shifting gears a little bit to sort of early things we've learned in this model. I know it's too early, now to have like full actuarial savings models yet, Sarah, because we've only been live since January. Well, not ever, it's only September. Not many women have had their babies who were in this program. But, what are some of the early, things that you're hearing, I think maybe for Kevin or Dr. Nakvi, of either sort of feedback on the program from providers or sort of early patient insights that you're hearing, since we've rolled the program out in January?
So I think so far the patients have been engaged, right? So I think from what I heard in my office, at least, it's been, very helpful because it's like, it's not, you don't have to do this, you don't have to do this, Wildflower will engage on that. But also, I'm actually looking forward to, what I'm looking forward to is actually the data analysis that's going to come out, because I'm hoping that I can find for instance, if I have patients who have been diagnosed with hypertensive disease of pregnancy, and if I can link and find populations using the zip codes, right, and kind of figure out where those incidents of preeclampsia or hypertensive disease is happening more, I can go into that community and do education, whether it's about prevention using low-dose aspirin, whether it's just access to blood pressure screening, whether it's also continuity. Remember, I know we've talked about patients entering maternity care, but it's also what happens the first year after giving birth, right? We know in this country, moms are dying, right? The biggest threat is the first year after delivery, okay? And for Black women or Black birthing individuals in this country, 3 to 4 times, right? That's what your slide said. You know, there's a higher mortality rate in this country. So going, you know, can we use this? Can we analyze it? Can we create something like this? This is a meaningful metric, right? Again, going back into the community, patient remains the focus. You're aware where the patient needs to be. They understand it, and not to minimize, not just minimizing, you know, food, where they live, where they work, but it's also the environmental impact of delivering care nowadays, right? So we can't minimize that as well. We all know we're living in 90 degrees weather, right? Fall, we were just joking about it earlier, like fall, I don't even know about fall right now. We're sitting in 90-degree weather in September. So a pregnant mom being out there with poor air quality, and what if she's living in, you know, asphalt city, right? No greenery, no shade. It makes a huge impact. So I think it's, again, tailoring maternity care to the patient and where they live. More so, we're coming out of those silos again, not to how they engage with the healthcare system, but, you know, we're going to get patients delivered safely in the hospital, but what happens to them afterwards? So that's where this is going to come down to.
And I'll add to that. Like, I think we've actually had, to your point, it's way too early for to understand where we are with the financials. But I think what I can tell you, so Atlantic does about 400 employee deliveries a year. Again, 9,000 on an annual basis. But so we are right at 200 running through June, so we're on target. More than 50% of those members are active users on the app, which I think is pretty impressive. And I think the other piece that really super proud of is that of those 50% of the people that are engaged, almost more than 90% of those patients are being treated by physicians that are actually on the Wildflower app for their practice. So that's our employed docs. That's you know, it's the independents. So those are, I think, some pretty significant. I think the dashboard is very interesting to see what they're using the app for. A lot of HR questions go back about coverage. A short-term, long-term disability. So I think what I see, I'm very happy to see that we're more than 50%, and that was with a pretty aggressive rollout because we wanted to get up and running 1/1. So I think as we get more word of mouth, we will get better engagement. And the one thing that, and I think Dr. McAfee, like, I think from our perspective, what I think is really kind of important about, and you hit on it, is, you know, at the quadruple aim, I mean, the one thing that physicians just don't have the capacity to do anything more than what we bring them. You know, at our Jim Barr, one of our ACO physicians, he'll tell you, it's just like, I just can't give anything more to these docs. And I think this navigation service really, not only is it a service to the members, it truly is a service to the OBs. Because I think if I literally brought in just an app to Dr. McAfee, I would have gotten that response, like anything but an app. And I think it's planning work that makes it, you know, it's going to make it successful.
And that's, thank you. And I think that's a great point. And I think to that end, you know, certainly one of the challenges with value-based care is that, you know, it's a small percentage of your patients who may be on a model at any one time. So how do you scale it, right? And we should talk about that in best practices of what you do when you only have X percent of your patients on value-based care models. But I think, you know, you all recently made a decision to sort of extend some level of this model, Dr. Nakvi, to your entire patient panel. And can you say more about why you decided to do that and what how that might help you going forward?
I think it was really just, again, engaging with the services that were provided. I didn't understand why one group of individuals would have it and another individual may not have it. Again, I wanted to make sure I had the playing field to be leveled for all our patients. So that's really what it was. It was more about that. And really, I think the human advocacy part is what really sold it to me, and then interim SDOH screening, interim perinatal depression screening, interim, all those surveys, right? We just don't have the capacity to do it, right? In our offices. So you need to kind of have somebody do that on the back end and make sure the patient's taken care of. And you're right, physician burnout is real. My colleagues just don't have time. Don't give them anything that would be like, we're already responsible for so many other quality metrics. Like just to add another aspect to it, that's not where the effort's going to pay off. The effort's going to pay off if you appeal to that individual or that clinician's core values, why they're into medicine. So that's really where the engagement comes in with the patient and the provider. So I think that's also the piece that helped me kind of say, advocate for it. And, I have a motto as well, and I'll just throw that in there right now. It's just basically, I'm designing a t-shirt. It's going to say educate, advocate, empower. And when we do that, even for ourselves and for our patients, that's my go-to. I'm like, why am I doing this? That's why I'm doing it. When we center the margins, when we basically take care of the people who are on the outside and create a system for them to answer the needs of the whole community. It doesn't matter if they're commercial payers, Medicaid, Medicare, charity care, it doesn't matter because they're all getting the same level of care. So.
Well, I have to, as a quick aside, I love all of your comments, and having been in digital health since 2012 when we started this company, so we've seen all the good, bad, and ugly. I mean, I think we were talking a lot about value-based care 2.0, which is we're passionate about, but this is also really, I think, delivering on what was the original promise of digital health. It wasn't to create another silo or just have consumer education outside of the clinical providers. In my mind, it was really to take the things you need to do with your patients and make them more efficient, make them more impactful, connect those dots, get that data, with, like you said, social screening and depression screening in between visits, monitoring in between visits, to really lift up the system. And I think we're hopefully being to scratch, not just at Wildflower, but generally as an ecosystem maturing. And I do think, getting back to value-based care is a really important part, because economically digital health also has to pay for itself. And it needs to come out of the impact on savings, quality, equity that we're talking about today. So it kind of all comes together. So I'm going to shift gears to the last little section, and then we'll take questions. I think we want to spend a little bit of time for those who are listening in who are, maybe excited about this vision or daunted by it. What are some best practices? What is advice of how you go about putting this in place? And I'm going to come back to Sarah and start with you. And we've talked a lot about the sort of blueprint of 2.0 value-based care. But what advice would you give to organizations who want to start evaluating this and take first steps? And maybe any operational best practices we've learned in doing this would be great too. So go.
Yeah. Well, I mean, you asked the actuary, so the answer is going to be data. But and the data is very important, and as much data as you can possibly get is important. But ask an actuary and I'll say, give me all the data. I want everything. I want it all at once. And that's not always feasible. And we've learned that. And we've also learned that you can get quite a bit from using different normative data sets or limited amounts of data from a potential client. And so you can really say a lot about the opportunity just from some limited data. And we've kind of mastered that a little, as we've evolved over time. So I would say, don't let data get in the way, but you get as much as you can. And then I think the thing that we've really learned is working in partnership with the providers is really how to make this like a unique proposition. And so we working with Dr. Nakvi and Kevin and their teams, and it's a powerful combination, especially for, so we've got the payer involved, we've got the OB involved, we've got the hospital involved, and then we view ourselves as kind of the glue that brings it all together. And then back to Dr. Nakvi, what you keep saying, that patient-centeredness, and so how do we link all of this back and bring it to the patient? And I think that's where we found, in those partnerships is where we found that things are really going to be successful. So I would, those are the kind of the couple of things I would think about.
That's awesome, Sarah. Thank you. Kevin, putting on the health system hat for the health systems dialing in, what advice would you have for health systems who maybe want to embark on this type of journey?
I think a couple of things that we did right was, so Atlantic's, I don't know, I think 19,000 employees, give or take, so we cover 30,000 lives with our employees. And by ourselves, we didn't have enough critical mass to make a statistically valid actuarial model. So, and I think the other thing too, at least in the New Jersey, New York, Philadelphia metro market, the OBs have cross privileges at many hospitals. So I think, finding that critical mass, bringing those right partners into the room, really was critically important from day one. I think, at any hospital that's going to be, going into this, if they think it's potentially a path down the road to engage, again, those 65% of members before they even get to your facility, I think that is a really great opportunity. I think the finance people on this call are asking, what about those NICU babies? How do you do a value proposition with those? Those can be $1 million babies. I think, at least from the Atlantic perspective, we're saying, because those $1 million babies normally don't leave that employer, because employees are often scared to leave their job because they have the coverage. So if we can work with our OBs and with some of these tools that we're talking about to prevent some of those, I think that's still a win down the road. But I think it's really finding the right-minded partners, being other hospital systems or maybe a local employer who's got a lot of population in that area. And quite frankly, on the other side of that, the clinical champion that can help you push this through the politics that are going to exist within any healthcare system.
Yep, absolutely. And last but not least, Dr. Nakvi, from your perspective, as people think about, again, advocating for this, it's obviously crucial to have the buy-in of the clinical care teams. And so, how would you advise organizations looking to take this on to really help, drive that OB provider buy-in?
Right. So I think none of this would have happened if you didn't have a leader, right? And a leader who creates a leadership, right? Those are two separate things. So you have to have that in an organization, because this resonates with me, but how do I execute it, right? Mm-hmm. So you need that backing. And you need a leader who has the foresight to look ahead. The other thing is that I said it earlier, that it's not just me, there's a whole team behind me. And then, of course, that team to say, oh, we see something in you. Can you be the voice of, this endeavor that we're trying to, start off? I don't think I got much of a notice. I think I was just.
Hello, nice to meet you.
Nice to meet you. This is what we're kicking off. So welcome on board. But just, interacting with different people from different backgrounds. And again, that just, it helped me so much. But it's also creating an environment of learning for yourself and for others. So it's bi-directional. And the last thing is, I would tell anyone who's taking this on, is just physician burnout is real. And I said that before, but I cannot emphasize enough that that's where we have to kind of be creative and how we go about reducing that burden and make it the easiest thing that we can for physicians as well as for the patients, because the patient's going to benefit at the end of the day when the clinician is more engaged, right, in the room with them and highlighting it. So But yeah, without leadership, without a team effort, this would not be possible where we are right now. So absolutely.
And I'll just add in there, like having the right team to do all the analytics. I mean, that really was a tremendous amount of work between Sarah and my team. I mean, that was, weeks worth of work. And I think you got to really have some really strong people, which lucky enough, knock on wood, my team is. Because
they are, yeah, definitely.
It's an outstanding job. Without that, we probably don't get from point A to point B, because everybody had to feel comfortable with those numbers before I even engaged with Dr. Nakvi.
Mm-hmm. Absolutely. Great. It was been a great partnership on that front. And I just want to add in one quick anecdote to Dr. Nakvi's last point. Then I'm going to get to questions. We'll have exactly 10 minutes. To your point about physician burnout, I had a practice in a different market said to me, we were talking about, value-based care and this is independent practice. Like, the shared savings and upside financial benefits are fine. But what's really great is having these resources to have digital workflows, health advocates, things to help us be more efficient and effective as clinical care teams, because we just don't have enough time to do everything we need to do. So I think that is just it's in some ways even more important than having, the shared savings are great. Everyone will take, upside, but I think it's just really important that it's a multifaceted value proposition for practices, right?
Right. Absolutely.
Well, hey, we have so many questions. I'm going to start asking questions. I think the first one will probably be a tag team between Dr. Nakvi and Sarah. The question is, thank you, Maria K. I won't attempt your last name for this question. How does the workflow work from the provider? How do patients get into the application? How are they referred? And I think as we answer that, again, this challenge of figuring out which patients are eligible for what is something that we've worked on. So maybe we can address that as part of answering that. So who wants to start?
I could start just from selecting the patient, So pretty much I look at any tool like such as Wildflower, right? So it's more, number one is education, right? Do I have an education platform? So those days are long gone where you had a folder you handed out to your patient that had, the prenatal course highlighted. These are the tests you're going to be going for. These are the don'ts of pregnancy. I will be honest, I still have that folder because you never know where the patient's coming from, their health literacy, you just don't know. So I do have that, but I also know every patient walks in with a phone. Okay. So I tell them, I said, look it up right now. This is what we're going to happen. This is the platform. This is the app you're going to go to, and this is where you're going to learn. For patients who qualify for remote patient monitoring, what I do is I basically highlight all the high risk patients that we have, such as patients who may qualify for low dose aspirin, right? So I use that as a guideline for myself and to say, okay, obesity, right? We know our pregnant patients are delaying care, delaying childbirthing, right? So they're older. Obesity, right? If they classify to be under that category. They may have chronic medical condition. Overall cancer is on the rise, right? I just read a paper that said basically the young adults, right? The younger age of onsets, like in the 40s and 50s, rather than waiting for, in our late mature age, I guess, not to discriminate. But so it highlights that, who qualifies. So pretty much right now, and I don't have good data. This is more just what my experiences in the, in my office is pretty much I'm doing not just education, but RPM as well, because my patients are more complex. Once I have them, I actually write a quick little consent. And I basically say I need blood pressure monitoring twice a day, once a day, whatever it is. The health advocates take over, they engage with the patient, they start, teaching them. And the app itself, depending on trimester, they're pushing information out to the patient themselves. So again, whereas in the traditional model, the nurses would, I'll pop in there once in a while just to make sure. But this really is driven like per trimester. It's engaging with the patient constantly. So I find that's how easy it is. Obviously, how soon the blood pressure cuff can get to the patient is within like a week, So that's really remarkable too.
Yeah. And so from your order, Dr. Nakvi, we're receiving that electronically through the EMR, really basically real time. And then we're taking those orders, we're ordering the device, whether it's a blood pressure cuff or whatever. And then we are monitoring both the digital activity and the EMR activity, and our health advocates are monitoring that and making sure that they are reaching out when they need to talk to the patient through either messaging or the phone. And then that continues. And a lot of the patients are just engaging digitally because they're healthy and they just have, they need education and information. But for the most part, there are points along the way, but we are in communication and engaging with that patient throughout the whole pregnancy and afterwards as well. Hopefully they're still engaging with us.
Yeah. And I don't want to be too geeky here, but I think one important point is that, at Wildflower, we have the eligibility from the TPA for the HTC. So we know at the point of care who is eligible for these programs, so the provider isn't trying to figure it out. And that's true for all the practices participating. They're all a little different. Another practice, we get all their new patients, and then we run eligibility, and we can tell you which ones are eligible. So I think it's a geeky point, but it's important because otherwise it's hard for providers to adapt their workflows to just one group of patients on a value-based design. You kind of have to know who are which or which. So,
and I will add, that's really tremendous. That's a tremendous boon. Like where I don't have to think about it, it's really great. As a provider, it just happens. So who it is.
Absolutely. There's so many good questions. I don't even know how to. I'm going to shift to one. I think we haven't talked about this. Denise M asked, "Are quality measurements integrated into the model, and what are you using, and how do you help providers understand quality?" So I think between Sarah and Kevin, we could answer that one. Sarah, do you want to start?
Yeah, I can jump in. I do believe that any value-based care model must have some sort of quality metrics. And we do have a set of quality measures, and they are somewhat HEDIS-based, and then some other ones as well that we've all agreed upon. And then the way it works for us is that we are, when there are savings at the end of the measurement period, those savings will be distributed to the OBs based on how they perform on quality measures. If everybody does great on the quality measures, then the distribution is relatively even based on the number of patients. But if someone is doing particularly well or particularly less well, then they may not get as much of a payment. But it's definitely, it's meant to be more of an allocation tool than a yes/no binary. You won't get anything if you don't meet certain quality measures. We're not trying to do that cliff kind of methodology. And so once there are savings to be shared, we're tracking, by the way, we're tracking all those measures plus other ones along the way and reporting on that to the practices.
Mm-hmm. And go ahead. There's a lot of questions.
Sarah said it perfectly. We're good. No, Sarah said it perfectly. It's standard. Yep, a standard, quality pay performance model.
I have a question coming for you, Kevin. Sit tight. But really quick, there's a bunch of questions in the chat about Medicaid. So to be clear, in the HTC population, this is of all commercially insured health system employees primarily. However, in this market, in Q4, in one of the HTC systems, we will be launching a program for Medicaid members. So obviously, we want value-based care models to be extended from not just being commercial, but also Medicaid. So that is maybe a future webinar. We can do this on Medicaid. And this is also sort of a forward-looking question. It's a really good one, Kevin, and maybe one we'll end on for you is Denise M is asking about how do you reconcile the OB episode model with your primary care ACO models, and how do those fit together or not? And how do you subtract those members out? So
okay, so right now we don't reconcile it against the ACO. We had just done that match to see how many of we looked at our ACO data, cross-matched it against all of the 9,000 deliveries. How many were within our ACO piece of it? So right now it's a separate bundle for our employees. I think the next phase as we look into it will be, how do we tie those 65% members into maybe a potential bundle? If, that's probably certainly down the path a little bit. And I think, again, going back to, we're using the tool as sort of a, to test the waters to see how this works. is that another tool that the ACO can use on those 35% of births that are already involved in the ACO to help potentially, because those are total cost of care contracts, to reduce maternity expense on those lives there. So this will continue to evolve as we learn more and work with the physicians, but that's ultimately the goal, is to really evaluate those two options once we got with 2 years worth of data to really dive into it.
Excellent. Maybe that'll be value-based care 3.0. Stay tuned, everybody. Hey, we are at the top of the hour. I want to thank everyone for sticking with us and really thank our panelists. You all are inspiring and amazing, and thank you so much for spending the time with us. And thank you, Beckers.
Thank you.
Yeah, thank you very much for having us.
Thank you.
Thank you so much, Leah. And we at Beckers would